What is pain? You know it when you have it. And I suspect that everyone in this audience has had a little pain here or there, a headache, a little sore elbow, a little back pain. Pain is hard to evaluate as a clinician. It's very important that we learn how to treat it. And in many medical school, we have two phenomenal individuals who I think will present a very well-balanced discussion of the topic. This is Dr. Ronald Schneeweiss. He is a professor in family medicine here at the UW. He is chief investigator for a very large grant that is, I think, changing our curriculum for our medical students. It's to teach them about complementary and alternative medicine. His philosophy is that he embraces what he calls a biopsychosocial approach to treating patients. And he likes to incorporate all kinds of alternative approaches to his healing methods. His medical degree was obtained in South Africa and his residency in Israel. He actually is past chair of the UW Family Medicine Department, and his CV is his curriculum vitae is very long. I noticed in there that he has been a visiting professor throughout the US and throughout the world, Israel, Japan, Taiwan, Malaysia. I want to emphasize his student teaching, though, in his introduction. He cares about our students, and he cares that we really get it right when we educate them. And so he has gone out, he's obtained grant funding, and he is really adding to our curriculum. He wants to give our students a greater appreciation for complementary therapies, such as acupuncture, chiropractic medicine, meditation. And he fosters in the medical students' understanding of the mind-body connection. And he also has long used hypnosis in his clinical practice. I think we're in for a wonderful presentation, and I want to thank you so much for joining us. There you go. Okay.
Well, good evening. I've been in family medicine for over 40 years, and I've been here in the University of Washington for slightly more than 32 years. So I know you're going to say you don't look old enough to have done all of that, but here I am. So I'm going to talk tonight about alternative approaches to health and healing. Now, this is also known as CAM. Who's heard the word CAM before? Okay, complementary and alternative medicine. The abbreviation, the jargon abbreviation is CAM, and the more recent term that's used is integrative medicine. Oh, there we go, integrative medicine. So that's what we're going to talk about. And these are the domains of alternative therapies. There are lots and lots of alternative therapies. And I'm sure many of you can add to the list that I have up there. These are the domains that the National Center for Complementary and Alternative Medicine have designed in order to try and accommodate not only the mainstream alternative therapies, but also, some that are on the, let's say, on the fringe more. The ones that I'm going to focus on this evening and that I'm going to incorporate into my talk include the mind-body interventions and alternative medical systems. And in particular, I'm talking about acupuncture and oriental medicine, since those are the most likely to be connected to the management of pain. I decided I would focus in on those. So here comes a question. Here's the question. I personally use daily vitamins and or other dietary supplements. Now that's aimed at the audience. Will everybody raise their hand who does that? Wow, that's amazing. Okay, I would judge that, Joanne, I don't know if you looked around, but that was probably about 90% of folk here use vitamins or other dietary supplements. Okay, that's good. I do too. I have personally consulted a CAM practitioner. Slightly fewer, but enough. And I think that bodes well for the medicine in the 21st century, which I believe has got to be some kind of complementary integration of alternative approaches to healing, as well as what I'm going to call the conventional medicine approach. So we've got alternative therapies or complementary therapies on the one hand. I'd rather use the word complementary actually, and on the other hand, conventional medicine. So why do patients use CAM? Let's have some suggestions. Thank you. Fewer chemicals. What else? The others didn't work, and very often patients, when the conventional medicine doesn't work, they turn to alternatives. And go ahead, what else? They're more accessible. Okay, you can get an appointment with an alternative provider. Okay, that's good. Sort of like the witch doctors. No, I'm just kidding. All right. Any others? Okay, there are some problems that alternative and complementary therapies take care of better than conventional medicine. And there was somebody here, we'll take the last one.
More personal care, more time.
Okay, more personal care and more time. Now, what I think we're talking about, and that's all correct, and what's interesting is that the vast majority of patients who turn to alternative therapies at the same time also use also use conventional medicine. So patients are wise. There are very few patients who only use alternative therapies. Patients pick and choose and decide what's right for them. And clearly what we're looking at here is that every human being is an individual. We can't put everybody into the same box. And conventional medicine tends to try and fit people into diagnostic categories, and in order that they can then apply a particular therapy to them. What we forget in this day and age of evidence-based medicine is that there's a lot that goes into healing. Not only the therapy that is applied, but also the physician's attitude, the whether or not they convey a sense of positive optimism, whether they communicate well with the patients. That's all part of the art of medicine. And we make a big mistake if we just focus in on the biomedical, on the medical hard science. I believe this saying was attributed to Einstein. I'm not 100% sure, but I think it's true. Not everything that can be counted counts, and not everything that counts can be counted. And that's an important concept to keep in your mind. All right, let's continue. So 60% of patients don't tell their physicians that they are using alternative therapies. Why do you think that is? Sorry? It will be dismissed. They think you're nuts for trying something else. In fact, they are insulted sometimes that you're trying something else.
They're personally threatened.
They feel threatened by your going to an alternative provider. Okay, well, we'll kind of cut to the chase. And the main reason why patients don't tell their physicians they are using alternative therapies is because the physicians don't ask them. The physician doesn't say to them, are you using any alternative treatments? Are you seeing an alternative or complementary provider? And the important thing here is that we have to see a lot more crossover from both sides, both from the complementary side and from the conventional doctor's side. So why do healthcare professionals need to know about alternative therapies? Well, the answer to that is reasonably straightforward. We need to know because our patients are going to ask us. So we have to have something, we have to have some knowledge about it, and we at least have to know where to go to get the answers. And you will notice I'm not talking about herbals and supplements here this evening. I just don't have enough time, and it's a talk in and of itself. But we also need to know, because there are herb-drug interactions. There are drug-herb interactions. There are herb-herb interactions. Patients come to us with complaints. They come to us with their blood pressure out of control. And the physician really needs to ask them, are you taking any alternative therapies? Because there are alternative therapies that can raise your blood pressure. Who here eats black licorice imported from Europe? Okay, black licorice imported from Europe has got licorice root in it. And licorice root can elevate blood pressure, and I won't go into the mechanism on that. And I've had cases like that, and so it's important to know. We need to know because there are interactions with some medications that are really quite dangerous, and physicians need to know it. And we need to know it in a way that is not pejorative, and we need to be able to communicate with our patients in a non-judgmental fashion. And we need to look to our alternative complementary providers as our colleagues. That is something that I am striving towards, and I hope we will succeed. And I think we are succeeding to some degree. Now, another reason why it's important to know is that 40% of adult patients in the United States use alternative therapies. This is a figure that has gone up. It has since 1990. It has now stabilized. In 1997, there were more visits, almost twice as many visits to complementary providers as there were to primary care physicians. And of course, there's an enormous amount of money involved. And that's probably underlies part of the tension between conventional providers and complementary providers. So my approach is non-traditional, but from a uniquely Western perspective. So my attempts are to kind of incorporate alternatives to that. But I would like you to pay attention to the fact, if I could get the little pointer to work here. Oh, here we are. To the doctor's wearing a white coat. And what's hanging out of his pocket? A stethoscope. And what's hanging on the walls? Certificates. They usually have nice golden seals on them. They're very impressive. Now, this creates the ambience that says to the patient, this guy is qualified, this person knows what they're talking about, I can trust them. That's part and parcel of this whole issue of the, the non-specific factors that go into whether or not an encounter with a doctor is a healing encounter or otherwise. So here is what people say. When I graduated from medical school, we were told that alternative therapies and complementary therapies are quackery and nonsense. And so the question is this a myth or is it true? And I think it took me many, many years before I reached the point where I was comfortable both talking to a complementary provider, being seen talking to a complementary provider, and actually finding a great deal of joy and a lot of satisfaction in finding out more about what they do for patients. And they do things that are clearly more successful than we do, especially when it comes to time, personal contact, and a sense of the patient that they are participants in their own care. I'm actually going to just very briefly touch on this because when it comes to science and scientific evidence, what we're looking for are what I know the gold standard is the randomized controlled trial, where to the extent possible, the investigators are blinded as to who, and the patients are blinded as to who's getting the active treatment versus the non-active treatment, and that is the gold standard. And we usually look for a number of them that point in the direction of a positive outcome for us to say, yep, that looks like it does the job. And then, of course, there are other kinds of evidence. Unfortunately, when it comes to complementary therapies, the evidence today is slowly accumulating, but it doesn't reach the level of the scientific evidence that is demanded by many conventional doctors. On the other hand, conventional doctors need to be more humble because there's a lot about conventional medicine that doesn't meet the standard of multiple randomized controlled trials that point to say we are doing something that has been proven to work. So let's talk about the placebo. The placebo is an inert pill or a sham treatment that is thought to have no therapeutic effect. And in research, a placebo is used in the hope that it will produce no therapeutic effect. You want to isolate out these non-specific factors from the actual treatment that you are testing. On the other hand, in clinical practice, we talk about the placebo effect, and what has become more popular today is the meaning response. What does this all mean to the patient? So in clinical practice, a placebo is used in the hope that it will produce a therapeutic effect. So that's a real difference. We, doctors in medicine, conventional doctors, as do complementary providers, depend heavily on using placebo. Are there any doctors in the audience? None. Are there any would-be doctors in the audience? Okay, we've got some wannabe doctors in the audience. Every doctor uses placebo. And you may say to yourself, I don't want my doctor using placebo. But the truth of the matter is we all do it. Now, we used to do it in a way that deceived the patient. We no longer do that. If we're going to use placebo, we need to be relatively upfront about what we are doing and how we hope that it's going to help the patient. So my colleague Peter Curtis, who's now a retired professor from North Carolina, investigated the literature, and I don't have the entire package of literature that supports this, but he pointed out there are many, many factors that go into the process of healing and the doctor-patient communication. So the clinical setting is important. Either you're going to have waterfalls, greenery, you're going to have sterile white walls, you might have lovely pictures on the wall. There's the famous study that was done, I believe, at Columbia, where patients post-operatively were either put in a room that had a blank wall, or they were put in a room where the wall had a picture of a beautiful pastoral scene. And the patients who were in the room with the picture got better quicker, and their length of stay was shorter. Now, this talks about ill-defined factors that go into our healing. Patients need to have confidence in the care that they're getting. Physical touch is very important. The doctor-patient relationship, expectations of outcome. What is the message that the doctor is going to give the patient in terms of what they expect as the outcome? Medications, tablets, and the color of the tablet's important. Now we're getting up in the, we're kind of ramping up the effect that these factors have on patients. We're using labs. We throw them into an MRI or a CT scan. Who's been in a CT? Okay, fair number. Who's been in an MRI? Oh my, look at that. So many more patients in an MRI. Much more expensive, but anyway, okay. And then manual therapy, hands-on, manipulation, massage, chiropractic manipulation. Very powerful image for a patient. When you crack some bones, that's good. Injections. If I'm going to give a patient an injection, you can imagine the impression it makes on them. When I was a medical student, I worked in a free clinic, and I remember the very first patient that I ever gave an injection to. She was a rather large lady, and she was lying on the bed, and the nurse instructed me where I should put the injection so that it wouldn't hit a nerve. So there I was, and the patient went, "Oh!" And she said, "Man, that was a jolly good injection." And then, of course, surgery. There's nothing more dramatic than doing surgery. You're going to cut somebody, that is dramatic. And we'll talk a little bit about all of those. So here's a study that was done in a medical school. Second-year medical students, there were 100 medical students in the class. 56 of them volunteered to participate in a study of a sedative or a stimulant, a pill that either had sedative or stimulant properties. And they knew they were going to be randomized. They weren't told which pill or which capsule they were going to get. So they either got, the colors didn't come out all that hot. They either got a single blue capsule or 2 blue capsules. They got a pink capsule or 2 pink capsules. So what happened was they took them off to the laboratory where they didn't know what was in the little envelope that they were given, and they were not told that some of them got a blue, that some got a pink, some got 2, some got 1, and they then went back to the lecture. They had a 1-hour lecture, and following the lecture, they were asked whether or not, they had a whole series of questions, having, of course, taken some baseline data, and what surprisingly was that the students who received the blue capsules were significantly more likely to report that they felt less alert and more drowsy. Now that's pretty astonishing because both capsules were placebo. So this just shows you the power that the mind has. You see, blue is calming and nice, and red is pink, get me going. So it just goes to show you, color is so important. That's why drug manufacturers are very careful about the color that they assign to the different tablets. Of course, the shape may be important too. Here's another interesting study. This was a study done back in 1987 by this general practitioner called Thomas in Britain. And what he did, this is quite amazing. What he did was he took 200 patients in consecutive clinic sessions. They were probably approximately about 4 or 5 patients at each clinic session. And for if the patients had non-specific symptoms, they presented with a symptom for which there was no diagnosis. And the physical exam showed no diagnosis. He then took out a card and randomly gave the one set of patients a positive message, a positive treatment message, and the other set of patients a negative treatment message. So these were 200 patients, and the positive consultation, listen carefully, the patient was given a firm diagnosis and was told that he would be better in a few days. The he and she are interchangeable. If a treatment was given, patient was told that in the doctor's opinion, the treatment would make him feel better. Now here's the negative consultation. I cannot be sure what's the matter with you. I think you may have X, Y, or Z. And if a prescription was given, I'm not sure that the treatment I'm going to give you will have an effect. Now, those are 2 different messages. And doctors, young doctors in training, are not taught to pay attention to the messages that they give their patients, because there is a healing component to giving a positive message. Now, you don't have to give a positive message that is totally unrealistic, but you have to be aware of what you are saying. And there's a whole long story about that, but I'm not going to go into the detail. So of the patients who were given a positive message, 2 weeks later when they were interviewed, 64% felt better. And of the patients who had a negative message given, or not a positive message, only 39% felt better. Now that's dramatic, because that really says something about this whole ambience, this whole package, the whole gestalt of who the doctor is as a healer. This, by the way, is one of the most dramatic stories that I've come across that talks about placebo, and it deals with this placebo and surgery issue. There was a time when I was a medical student when the technique of doing a coronary artery bypass surgery was not available. It wasn't possible. The technology was not known. And patients who had heart attacks or had angina, they were treated with this was a very clever idea. There's two arteries on either side of your breastbone. They called it the internal mammary artery. And the idea was, if you if you just simply tied them off, they're non-essential. But if you tied them off, they also give some blood to the pericardium and the myocardium, to the heart muscle. And the idea was, if you cut them off, the body would respond by increasing the number of blood vessels that this particular artery supplied, because that's what the body does. It's called angiogenesis. So if you cut off the blood supply, the body will find alternative channels. And it took off like gangbusters. Patients, you go into the second intercostal space, you isolate the artery, you tie it off, and the patients were doing so much better. They felt better. They used less medicine. This had never been subjected to a randomized controlled trial until Leonard Cobb, here from the University of Washington, decided he would do one of the earlier double-blinded randomized trials. Now, the curiosity is that there were only 17 patients in this whole study. I'm not sure that the study would actually get human subjects approval today. But what happened was that these patients were told that they would either have their arteries tied or they would not have their arteries tied, and would they be willing to participate in this very important study. And 19 brave souls said yes. So the patients were all prepped. They went down to the OR, the operating room. The surgeon in the operating room was handed an envelope, a random envelope. The envelope had a card inside that said ligate or don't ligate. Every patient had the incisions made. Every patient had the arteries isolated. And the patients didn't know who was ligated. Certainly the surgeon knew, but the surgeon wasn't involved in looking after the patients afterwards or in making any assessment or evaluation of how they did. So now you've got patients who've had their arteries ligated, not ligated, tested with stress tests before. All these are patients who had significant angina, who were definitely incapacitated by their problem, and they were followed up for somewhere between 3 and 15 months, and they had repeated check-ins. They were asked how many tablets of nitroglycerin they were using, how they were functioning, and so on and so forth. And at the end of the day, there was no difference between the two groups. No difference at all. So there goes, big money maker, but that's the way it is. That's how medicine advances. So this is the astonishing thing. There were 2 patients who were significantly improved. This is patient number 14. Let me get the little. Okay, you will see that at rest, okay, both before the operation and after the operation, the patients had no abnormality in their cardiogram. This is known as a T wave, and when a person has angina or decreased blood supply to the heart, the T wave gets inverted. There are other signs that are shown as well, but this is what is so dramatic. This same patient, when they were exercised on the standardized exercise test, 4 minutes into the test, when they were done before the surgery, had inversions of their T waves. And they also had chest pain. So this patient had chest pain, T-wave inversion, clearly had objective evidence of angina. After the surgery, look at what his cardiogram showed. This was 10 minutes of vigorous exercise, no chest pain, no inversions of the T-wave. This patient did not have his artery ligated. So this is the drama of the human resilience, the human ability to heal itself, the ability of the mind to affect how we behave and how we respond to illness. So let's talk a little bit about acupuncture. Acupuncture is, and I'm just throwing in some other examples here, acupuncture is probably one of the complementary therapies that is most acceptable to conventional doctors because it kind of fits our paradigm. And it's obviously a whole different worldview of how illness is or disease is caused, and the diagnostic methods are totally different, but patients seem to get better. I can tell you about a 60 plus or minus year old female patient who had upper back pain, and the upper back pain would come at night, and it was like lightning sharp pain in her shoulder. She couldn't sleep. It woke her up from her sleep. And this patient went to a conventional doctor. She was given steroids. She was given non-steroidal anti-inflammatories, and they helped a little, but they didn't help take the problem away. So her physician said to her, "Why don't you use acupuncture?" So she went to an acupuncturist, and the acupuncturist stuck some needles into where the needles needed to go, and believe it or not, after 2 treatments, the patient's problem went away. Gone. Now, is that temporal? Is it simply a matter of time? Or is it, in fact, that the acupuncture really worked? A few months later, the same problem. Back to the acupuncturist. Pew! Some needles in, pain's gone after 1 treatment. How do I know that? Because the patient is my wife. And I told her, go get acupuncture. So I think what we need here are physicians of the 21st century who are going to think very broadly, who are going to be willing to accept that there are alternative complementary therapies that maybe don't fit with the conventional medicine paradigm. But in its totality, I think that it offers patients much broader opportunities for healing. You've got to be kidding. Your back still hurts? Okay. Acupuncture is possibly effective for dental pain, post-operative nausea and vomiting, fibromyalgia, knee osteoarthritis, chronic back pain. Notice that those are all pain conditions. It's also, and the evidence for this, it's a mixed bag. There are some studies that come out positive, some that come out negative. It's not easy to say with certainty that acupuncture meets the standard of randomized controlled trials that point in the direction of efficacy. But what difference does it make if it works? What if it's only placebo? And I say only placebo in parentheses, in inverted commas, because I actually think placebo is wonderful. If I had something that I could offer patients that would cure them, it would offer them relief between 30 and 70% of the time, that would be dramatic. I have no therapy in conventional medicine that offers that kind of relief 70% of the time. It's called placebo. Complicated business, lots of ethical issues that are surrounding that. Other conditions where it's possibly effective have been in insomnia, epicondylitis, tennis elbow, version of a breech presentation, and as an aid in GI endoscopy. It's very calming. My wife tells me that with acupuncture, she felt very calm. It has that kind of effect. This was a study using a functional MRI, which is a investigation that shows you where the brain lights up when stimuli are given. So in the A section, this is where the patient was given a standard measured amount of pain. The patient was given acupuncture on the meridian that corresponded to what was needed, and look what happened. The response in the brain was substantially reduced. And when the patient was given sham acupuncture and had the pain applied, it was intermediate. Something is going on. There is something that is happening that we don't know enough about yet, but we can utilize that information to help patients with pain problems. Mind-body interventions are another very useful technique. I had hoped to give a quick induction with hypnosis, but we don't have time for it. But this is what meditation does in the brain. Lights up specific areas in the brain. Something is going on. Mindfulness-based stress reduction, which is a method of meditation, can be utilized in pain management, preventing recurrent depression, anxiety disorders. These are all studies that have randomized controlled trials that demonstrate efficacy. The problem is the trials are relatively small, the numbers aren't large enough, the numbers don't reach the significance for us to say with absolute certainty that it works. But for sure, it's an additional safe method that we can recommend to our patients. So integrative medicine, which is where I think we're heading, is informed by evidence, makes use of all appropriate therapeutic approaches. Healthcare professionals, including complementary providers and disciplines, to achieve optimal health and healing. That is what I would like to see in the 21st century. Doc, I can't believe drugs are the only way to handle my back pain. Isn't there an alternative? Something I can do myself? Well, it's impractical. You'd have to change your life, unlearn bad habits. Nobody wants to do that. So frankly, I've never even looked into it. Thank you very much. We have time for some questions. I've just put up some reliable web resources that you could turn to for information. The web has a lot of information that isn't well documented, and I would say these are the resources you should go to. Any questions? Yes, sir.
Certain individuals are psychologically susceptible to psychosomatic pain, or sort of the stereotypical hypochondriac. Do you think certain people are just psychologically wired to constantly assume that they're sick or they have some sort of disease or illness, even if there's no evident symptoms?
If I understood your question, I think what you were saying is, are some patients wired to have a lower tolerance for pain and to suffer pain more readily than other patients? And the answer to that is probably yes. What I can tell you is that I know with my work with hypnosis that patients have an innate ability to enter trance states. And I think that translates along the same line of what you're asking. So some patients have a lower pain threshold, some have a higher pain threshold. We all know that. Sir?
I was curious when the National Center for CAM was established and if it incurred a big political fight.
The answer to that is yes. The answer is that the Office of Alternative Medicine was created in 1994. Kicking and screaming, the NIH agreed to establish an office, and in 1998, the office was made into a center. Remember that a center is one down from an institute. So the National Institutes of Health have got different centers, and the National Center for Complementary and Alternative Medicine is one of them. They, in the past several years, have funded some really very important, well-done research in complementary therapies. They have a budget of about $130 million, and working together with other agencies, they probably fund to the tune of about $200 million studies in alternative therapies. We have one more question.
Some of the alternative approaches use different understandings of how the body works. Are those ever going to be incorporated and perhaps accepted within conventional medicine?
That's a very interesting question, and I do not personally have a good answer for you. I can tell you that to the best of my knowledge, in chiropractic, for example, the straight chiropractors excuse me, no, forgive me, I've got him. Chiropractic depends on the following philosophy. The philosophy is that if there are impingements on certain nerves in the spine, if the spine is out of alignment and there are impingements on nerves, it affects the physiology of the human body. I don't think anybody has been able to demonstrate that that actually is the case. We just don't know. There is attempts made to demonstrate that that is a plausible explanation for why chiropractic works. We know that chiropractors are superb at musculoskeletal disorders, and particularly the back. And we know that there are patients who are helped by chiropractic. I don't honestly know. I don't think that it's going to take a long time, and it's going to take the clear demonstration that that is a plausible pathway before it'll be incorporated into the medical curriculum. Similarly with acupuncture. Acupuncture works on the philosophy of chi, of energy channels. The channels have never been demonstrated. The chi has never been measured. So I think there's a real problem here. But I don't think it matters because we can work together. And actually, frankly, the medical school curriculum is so full anyway that I don't think we can add much more. Yes?
That probably just answered my question, but I'm curious about the study of the diet and nutrition and what people are eating and how that affects, and they're saying, you know, if you're following a certain diet and the nutrition that you're getting will help treat certain diseases, and so I'm wondering if that's incorporated into
Well, I think
CAM
everybody can subscribe to the idea that we should be using food and not tablets or capsules or supplements. And I think that the usual messages that are given are probably very healthy. I would say that we've had lots of disappointments in studies that have looked at the use of antioxidants for the prevention of heart disease. Vitamin E was shown not to be effective and possibly harmful. Vitamin A was shown to possibly increase the incidence of cancer. So this is a problem. And I think we, caveat emptor, we need to really be careful before we leap on the latest and the most spoken about wonder treatment that's out there. On the other hand, nutrition is vital. Medical students are not taught enough nutrition. Frankly, the nutrition that we are taught is much too much based on sort of the chemistry and so on and so forth, and far less practical in terms of what doctors can do to work with patients. So we have 12 hours in our curriculum currently. We have 12 hours of complementary and alternative medicine therapies in our curriculum presently. Maybe those numbers will change. Yes, please.
Isn't a lot of traditional medicine based on the placebo response, specifically the use of antidepressants? I think there was a study in January that showed that for mild to moderate depression, it's basically no better than placebo, but that's not to say it's not effective. So how much of traditional medicine is actually either placebo or expectancy response theory as well?
What do you mean by traditional medicine? Forgive me.
Conventional medicine.
Conventional medicine. Yeah, you're absolutely correct. The studies would suggest that antidepressants in some studies are no better than placebo. You know, gay vase, as they say in Chinese.
I have a question about a remark you made. You said in previous times patients could be given placebos, but they wouldn't be told that.
Correct.
And then you said now you would tell your patient if you're giving a placebo, which is bewildering. And then you showed a slide that said a placebo, if I interpreted it correctly, that a placebo effect would be having an attractive, professional-looking office, unguents, potions, the right clothes, the right pictures, maybe giving a shot of something. So if that's considered part of the placebo effect, I get that. But is that what you meant when you said that you would tell a patient if you were going to give them a placebo? And the second part of the question is about hypnosis. If somebody comes to you for a complaint like help losing weight, something like that, I don't know if you hypnotize for that, but the patient comes in with a positive wish that they hope that you can help them. So so does the patient attitude, is that part of the placebo effect in terms of they're willing?
Yeah, undoubtedly expectation is very important. When it comes to weight loss, the evidence is very mixed in terms of any treatment, as you well know. And I would regard hypnosis as an adjunct, but not as a treatment in and of itself. So I think anybody who wants to hang on to hypnosis as a crutch, that's the treatment that'll cure my problem, I don't think that that's the way to go. In terms of telling patients about placebo, let me tell you about my colleague Peter Curtis. He was a country doctor in Britain. He would go around and do house calls in this farming rural community, and in the back of his car he had a big jug of green liquid with bitters in it, and pink liquid and yellow liquid. And each one of them had a different effect. So the patients knew that the green liquid was for calming the nerves, that the red liquid was for providing energy and stimulation, that the yellow liquid, God alone knows. And he would drive around and he tells a story of this farmer who came out and stopped him and said, "Hey, doc, stop. Please give me some of that green bitters. It's really good." It was placebo. Did he tell him it was placebo? No, he didn't. But the patients believed that it worked. And for gosh sakes, if it helped them to function, why not? On the other hand, we are faced with the problem of transparency. We are faced with the issue of being honest with our patients. We are faced with the issue of getting consent from the patients. So it makes it a little bit more tricky. On the other hand, one could say to a patient, look, here is a treatment that I think will help you. I do have another treatment. The other treatment has side effects and potentially could cause you harm. Which treatment would you prefer? But I think we're done. Thank you.
Thank you. That was perfect. Thank you so much.